Hello everyone, again my name is Vadim Koshkin. I'm here with GU Oncology Now. And today again I'm talking to Dr. Arlene Siefker-Radtke, a renowned bladder cancer expert, and she will be discussing the results of her NORSE study. And Dr. Radtke, if I can just have you maybe quickly summarize the design of the study and the patient population.
Well, thank you so very much for having me. And as you know, there's been early clinical evidence suggesting FGFR3 altered urothelial tumors are associated with an immunologically cold tumor microenvironment. As a result, we thought that combining erdafitinib with an immune checkpoint inhibitor, citrilimab, which targets PD-1 expression, may help improve the efficacy of these treatments in patients with metastatic urothelial carcinoma. When we look at the clinical trial design, we sought to meet an unmet need, patients with cisplatin ineligible urothelial tumors, where it's estimated over 50% of urothelial cancer patients are not candidates for standard of care cisplatin. And typically gemcitabine carboplatin has been used most commonly in this patient population. Although another targeted strategy, enfortumab vedotin with pembrolizumab, has recently been granted accelerated approval using a similar clinical trial approach. The design was a randomized, non-comparative cohort trial, similar to enfortumab vedotin with pembrolizumab, where patients who were cisplatin ineligible were randomized to erdafitinib only or the combination of erdafitinib with citrilimab. When we look at the characteristics, we saw, as anticipated, very low expression of PD-L1. Less than 10% of patients had PD-L1 CPS scores greater than 10. So again, reflecting that immunologically cold tumor. We also saw enrollment of about 20 to 30% of patients with poor performance status of 2, which has historically been a challenging cohort of patients to treat. Despite this, the results were very promising. Erdafitinib only had an objective response rate around 45%, which translated to a median progression-free survival of around 5.5 months and a median overall survival of around 16 months. The combination of erdafitinib with citrilimab also appeared promising, where we observed a 55% objective response rate, which translated to a median progression-free survival of around 11 months and a median overall survival of around 20.8 months, which is now entering the threshold of other targeted strategies in the cisplatin ineligible space. So my conclusions from this trial is that erdafitinib as a single agent shows similar clinical efficacy as what was observed in second-line trials, and the combination saw an improvement in objective response rate with more deeper responses regardless of CPS score, and responses regardless of whether it was a fusion or a mutations observed on the tumor. And as a result, it's worth studying this combination further.
Well, that's an excellent summary. Thank you so much. Just to follow up on a few things about the trial design, how many patients were in each of the non-comparator arms?
We enrolled about 45 patients in each arm.
And as you mentioned, the data on the response rates were fairly consistent with what we've seen with the erdafitinib before.
That is correct. So we didn't see any loss of efficacy with single agent erdafitinib. We didn't see any increase in efficacy, but again, it's a targeted strategy, and this is similar to what's been observed with other targeted agents. Perhaps it's more based on the target rather than the disease space.
And can you comment on the choice of drug of citrilimab as the checkpoint inhibitor for this study?
Well, the use of citrilimab was chosen because it was supplied by the company. And as you well know, sometimes it's challenging to have companies working together due to intellectual property rights. The other option would have been a standard of care option, but in this case, they had citrilimab available for development.
So then my next question is, of course, do you think that the outcomes and the results that you're seeing would translate to other checkpoint inhibitors? Is this a class effect if you had used something like pembrolizumab or nivolumab or something else?
Well, I do suspect it is a class effect because we haven't seen substantial differences in objective response rate comparing PD-1 versus PD-L1 inhibitors, although it is intriguing that most of the immune checkpoint inhibitors that are still approved today were the PD-1 inhibitors. But whether
Absolutely.
that's truly due to a targeting change or issues with clinical trial design is challenging to say. But I suspect it is a class effect that would be observed with other immune checkpoint inhibitors as well.
And my further question is, you do see somewhat higher response rates and as well as better outcomes in the combination versus erdafitinib, but in your opinion, does this suggest synergy between these two drugs or more of an additive effect in this population?
Well, it is challenging to argue for synergy, right? You really need to see a phenomenal response rate to argue that we're seeing a synergistic effect. It's also challenging to compare cross trials because this trial only enrolled FGF-altered urothelial cancer patients. So at the moment, it does speak to perhaps more of an additive approach. We see that 40 to 45% objective response rate with erdafitinib only, maybe some addition with the immune checkpoint inhibitor. Also under the knowledge that PD-L1 tumors or tumors that were PD-L1 negative historically haven't responded or done as well with an immune checkpoint inhibitor. So we always have to analyze our data with a grain of salt and design a confirmatory trial if we're really trying to prove synergistic or immunologic benefit.
Absolutely. Very difficult to show that, as you mentioned. Was there excess toxicity from using the combination versus erdafitinib?
The toxicity that was reported was similar to what's been observed with other drugs of each of these classes. With treatment with erdafitinib, we saw the typical FGF-related toxicities. Hyperphosphatemia was observed, mucositis, we saw hand-foot syndrome, and then the central serous retinopathy, which is considered to be a class effect of other drugs that inhibit the MAP and MEK kinase pathways. We saw a similar frequency of these effects that were no higher or not significantly less. The central serous retinopathy was around 20%, and patients were screened at baseline with ophthalmology exams and optical coherence tomography, both at baseline and at monthly visits for the first 4 months on treatment.
Absolutely.
And then with the immune checkpoint inhibitor, similar class effect to other immune checkpoint inhibitors, the autoimmune conditions that may develop due to treatment with immunotherapy.
Yeah. And then you mentioned earlier that overall it seems like this is an active combination. What are the next steps, if maybe you can comment on that? Is it a larger trial, like a phase 3 study of this, and what would a trial like that look like?
Well, to confirm evidence of benefit of the combination, we would need a larger clinical trial showing proof of concept. And the challenge with the FGF-targeted trials has been the requirement for screening. A lot of companies developing FGF inhibitors have not been able to complete screening in a timely fashion. Multiple trials have closed. So I really think it's phenomenal that all of my colleagues and Janssen supported this work and all of the efforts that were made to screening patients to enroll them on this clinical trial. But I think understanding how these combinations may even have additive effect would be beneficial, and especially in superficial urothelial tumors where FGFR3 alterations may be present in up to 60% of superficial urothelial cancers. And as you may have seen, Janssen also has this pretzel-type strategy, a drug-eluting pretzel. So wouldn't it be fascinating to see trials down the road with erdafitinib and maybe an immune checkpoint inhibitor in this drug-eluting pretzel to see if they can put us out of a job and patients no longer develop metastatic disease because we're able to treat their superficial tumors so extraordinarily well.
Yeah, that's a great point. Yeah, we see a lot of these promising therapies moving earlier and earlier in where we use them for patients. Is this basically what you see as the future, really, for FGFR? inhibitors
I
and
think-
erdafitinib.
Yeah, I think studying it earlier in the disease space is very important, as it may help us control superficial bladder tumors, keep it from transitioning to invasive disease, and help patients keep their bladders, not only preserving urinary function, but sexual function, which is so important to our patients as well. So earlier disease spaces become important. And then understanding how to sequence them with the other targeted strategies that are becoming available may be a very important thing to learn.
Yeah, absolutely. Yeah, a lot of things I think to look forward to in this space. Well, thank you again for sharing this for this interview and sharing this data with us. And again, very promising data from the NORSE study. And congratulations to you and the investigators.
Oh, well, thank you very much, and thank you for having me.